let me just tell you, thanks, Fola. So very briefly about the National Safer Supply Community Practice. Some of you may already know us and be members of the community practice. For those of you who don't know us, we are funded by Health Canada's Substance Use and Addiction Program. The community of practice is led by, in collaboration with 3 organizations: London Intercommunity Health Centre, the Canadian Association of People Who Use Drugs, and the Alliance for Healthier Communities. The goal of the community practice is to support the scale-up of safer supply programs across Canada. The focus is predominantly a medical model of safer supply because that is the most feasible model at this point in time. However, we do participate in a lot of conversations and advocacy around the development of a non-medical model as well. We really focus on a medical model that's delivered from a harm reduction and public health approach. And what do? We do lots of stuff: knowledge translation, workshops, capacity building, training, developing tools, lots of working groups happening right now. We do have a prescriber consultation line. So if you are someone who's involved in providing safer supply, or you work with people who provide care for people who use drugs, let them know that we do have a consultation service for people who are prescribing safer supply medications. And we have an amazing resource library on our website. If you're interested in joining the community of practice, you can, oops, I've gone too far there. You can go to our website. We do have a certificate of attendance available for today. We'll drop a link in the chat bar about halfway through, and you click on that link and you'll get a certificate of attendance. And just a little heads up about what's happening in September. So we have these hot topic meetings the last Thursday of every month. For our September hot topic meeting, which will be September 29th, we're having a bunch of amazing teams and people representing different teams in Quebec coming to speak to us about the work that's happening there. It will be a presentation that is done in French with English translation. And yes, please go to our website if you'd like to find out more about us, find a bunch of amazing resources, see old webinars that we have archived. We have an incredible library on there of resources, and it's also a place for you to join, to register as a member. And with that, let me stop sharing and let me pass it over to our moderator for today. Thank you so much, Keri, for being here, and I'll let you introduce yourself and our panelists. Thanks, everyone.
Oh, hi, everyone. First, I just want to acknowledge that Hawkfeather and I both work for a group called Parents Advocating Collectively for Kin, and we are calling as we are settlers from the stolen lands of the Squamish, Musqueam, and Tsleil-Waututh nations in so-called Vancouver. We recognize and respect Indigenous peoples as traditional stewards of this land and the relationship that exists between Indigenous peoples and traditional territories. I work as an administrator, advocate, and childcare respite worker for PAC. Before that, I was working 12 years as an outreach worker for the STOP team in the downtown east side, which included providing supports to pregnant women and new parents who needed a harm reduction approach. So very familiar with Chi Way and Fur Square. I'm not sure if they have those sorts of programs in other provinces, but I guess we might hear about that from the presenters. So with that, I will introduce our first speaker. That is Julene Rawson. She's from Prairie Harm Reduction in Saskatchewan, and she's going to talk about the program they have.
Good morning, everyone. So as Keri said, my name is Julene Rawson. I am the Director of Family and Youth Services with Prairie Harm Reduction in Saskatoon, Treaty 6 territory here. And so I was asked to talk about the prenatal pilot program that we previously had. We no longer have that running to its capacity. We still do prenatal supports, absolutely, with any of our moms that would like supports. But back in August of 2017, we were approached to be a part of this prenatal pilot project as an effort to stop apprehensions at birth. And so because of the birth alerts that were still happening, there were some social workers and some community agencies that wanted to try to prevent as many apprehensions at birth as possible. And so this prenatal pilot program was aimed at improving the coordination of services and supports for moms who were at risk of having their child apprehended. So the best way to do that was to keep them with their parents, to provide supports for them in any way that we can, and it required a lot of open communication between social services, between mom, and between all of the supports. And so there would be a referral process. If we felt someone was in need, they would need to be in their 3rd trimester and at possible risk, and that could be due to previous apprehensions that they've been involved with, historic or current substance use, historic or current domestic violence, apparent physical, mental, or cognitive limitations, any of those things that might raise a bit of a red flag in wanting to apprehend those newborn babies. And so we would meet with the parents. We would explain what this prenatal program means for them, and if they were wanting to consent to be a part of that program, then we would fill out that referral form with them. And so by consenting to be part of this, it means that they are agreeing to share information between their supports and the Ministry of Social Services about their progress and their case plans, including sharing information about their health, history of child protection involvements, any housing related issues that they may be facing, any relationship issues they're facing, any mental health issues, substance use, anything that could affect their safety or the safety of their baby, and then allowing us to work together with them to come up with plans, to create safety plans so that mom and baby would be able to be safe. And so this was a voluntary program, and they could opt out at any time. Within our first year, we had 19 moms referred to our program, and all 19 apprehensions were prevented. So that was seen as a really wonderful success, that they all got to go home with their moms. We had another really interesting success throughout this program as well. We had a mom who lost her older children to social services, and they were in care permanently. She had done a parental assessment in which she was deemed that she would never ever be able to be fit to parent ever again. And she became pregnant again. And through our prenatal pilot project and working with all of these supports, we were actually able to overturn that parental assessment, and she was able to go home with her baby. And she's got a second baby as well with her today. So that was like a wonderful, huge success to see, and continuing to support her. In the event that apprehensions had to happen, because it was never a guarantee that they wouldn't happen, but we would do everything we can to support, to try to prevent that. So in the event that there was an apprehension, they would work really hard to try and find family to place the child with instead of within the foster care system. And so try and keep the families together that way. And so we did have one baby that was taken because mom deemed too developmentally delayed to be able to parent. And an aunt had stepped up and had agreed to take the baby and agreed to have mom remain involved as well. And so mom and baby still got to bond and still got to have that relationship, which was really, really, really wonderful. And then in February 1st of 2021, Saskatchewan ended their birth alerts, which was wonderful. We've been waiting for that to happen. And so at the end of those birth alerts, this prenatal pilot project also came to an end. But our supports have never ended. So we always support any of our moms prenatally, and we will continue to do so. And, you know, if it's helping them find housing, if that's taking them to all of their appointments, meeting with their social workers and helping to advocate on their behalf. Whatever supports that mom needs, we're there to try and help her out with that. So that is, in a nutshell, our prenatal pilot project that we previously had, and some of the supports that we still continue to offer.
Just quickly, since you've been doing this pilot project, there was just that one apprehension then?
There were some other apprehensions as well, but that was within the first year. But anytime that they did have to do an apprehension, it was worked really hard to place them with family. So instead of just an automatic taking of the child, then it was let's work together. And because they were involved in this program within their third trimester, planning was able to take place. And so it wasn't ever a huge shock. It's still traumatic, as always. Any kind of an apprehension is always traumatic. But it was something that was able to be a bit planned for if supports weren't quite working out. Yeah.
And those experiences with child protection, you have a collaborative relationship with them. They worked okay, or?
We do. We have a very good relationship with our social services, child protection services here in Saskatchewan, with our family support program. And so it was actually a couple of social workers who had approached us wanting to start this prenatal pilot project and trying to prevent apprehensions as well. And so child protection services really respects the work that we do on the prevention side of things, on the harm reduction side of things. And so they really value our input, they value our opinions, they value our supports. And so that all leads to helping to prevent apprehensions, absolutely.
Okay, well, there are just a few questions and then we'll save the rest for the end. But I guess I more or less asked there, someone's asking if you collaborate with child welfare, and it sounds like you do.
We collaborate with child welfare in trying to keep the families together in any way that we can, and providing supports for families and reunification. So if there is an apprehension that does have to happen, okay, what needs to happen to reverse that and to get that family reunited as fast as possible? And so we would be able to step in providing those supports as well.
So the collaboration doesn't happen until an apprehension is.
We can collaborate. Currently, right now, we'll collaborate even prior to an apprehension. Like we'll have social services sometimes say like, hey, we want to refer this mother to your program. There was recently a DV situation, and they could use some additional supports. Children are currently remained in their care. They may have opened a file, but the children have not been apprehended. And they want us to provide some additional supports to be able to keep them in their home, and we'll absolutely do that all the time. If there is an apprehension that's happening, sometimes they'll even phone us and say, look, we had a situation happen on the weekend. We're going to mom's house right now. We have to apprehend the children. Can you come? And so we will go there to be that support for mom and help her understand what is going on and what the next steps are and how we can be there to support her to get her children back. Because sometimes, like when an apprehension is happening, it's extremely traumatic. And sometimes like you can't, just through the trauma and just having that tunnel vision of like not being able to hear or really understand what is going on. And we can be there to hold mom, to support mom, and then to guide her through the next steps and help her to understand what's going on. And as well, we can be there to also ask questions that she may not think of as well, as far as like what happened, is this really necessary? And is there another plan that can come up?
Okay, and lastly, the rest I'll save for the end, but do you have an addictions medicine provider on your team, and is your program abstinence-based?
No, we are not abstinence-based. We're harm reduction. So we work with safety planning And as far as what was the addictions
Do you
services
have-
provide,
Do you have an addictions medicine provider on your team?
we do not. No.
Okay, so any more questions we'll bring up at the end of the panel. So now I'd just like to introduce Jenna Bly, a midwife from South Riverdale. It's a CHC's match program. And they will talk about the Eat, Sleep, Console and other tips, and probably do more of an introduction. Okay.
Thank you. I'm just going to share my screen. I have a few slides to go through. While I'm fiddling with this, many of my colleagues are on this webinar, so it's really nice to see people I know and the people I don't know. Like, I just want to acknowledge what an incredible group of providers is on this webinar. It's very intimidating. Like, everyone, I'm sure, could contribute to a panel like this in the work that they're doing. So thank you for having me. I'm very humbled to be here, joining from Toronto, from South Riverdale Community Health Center, we're governed by the Dish with One Spoon Wampum Belt Covenant. This is just the cover slide. So I will go through our program just very briefly. So we're called the MATCH program. MATCH stands for Midwifery and Toronto Community Health. And then we have a substance use in pregnancy pathway, which gets shortened to MATCH STEP. We're a salaried model of midwifery, which is relatively new in Ontario. So prior to 2018, all midwifery was funded in one way, with midwifery practice groups working sort of independently together, midwives only. And so in 2018, our program, along with some others, was funded with some different funding models. Ours is a salaried model embedded in the CHC. So we work in a multidisciplinary team with primary care providers. We have a social worker on our team. We're very happy to have, we had someone who has been on leave, and so we've just gotten a new social worker back. Very excited to have her on the call today as well. We provide complete perinatal care, so prenatal, intrapartum, meaning labor and birth, and postpartum care. We also provide pregnancy options counseling and medication abortion up to 11 weeks in a team-based model of care. And you can just see kind of a snapshot of the clients that we're serving. So generally, we're focusing on people who are experiencing barriers to accessing good care. And many of the folks that we see wouldn't normally have ended up in midwifery care for a variety of reasons that I can speak more to if people want that. So when we didn't actually plan specifically to go into substance use in pregnancy, but when we arrived at the CHC, our community health center runs 2 safe consumption sites, or consumption and treatment sites, as the Ford government would like us to call them now, I guess. One is in our actual building and one is down the road. So we have many colleagues who are doing this work very frontline with people. And when we started meeting with all the different providers around the center, when we got here as a new program, it was very clear that the folks doing frontline work with people using drugs were expressing a need that pregnant folks were not getting care, and were often either sometimes in worst case scenarios delivering outside the hospital and without any kind of care at all, and then ending up in emergency situations, and otherwise just kind of presenting at hospital in labor with no plan, no care providers, and then experiencing, as I'm sure you all can imagine and understand, a lot of stigma and really a lot of kind of institutional violence that was happening in those contexts. And so our team started figuring out how we could provide this care. And I'll say it really has been collaborative and team-based and interdisciplinary, and I think that's really important. So you can see on the screen there just some of our guiding principles as we built this program. We work from a harm reduction standpoint. We try to provide care in a flexible way. And we really work to connect our clients who use drugs with a variety of support. So we've worked very closely and built relationships with our obstetricians, who we already have relationships with at our hospital as midwives. But a couple of OBs have really stepped up to support us in this work. So we've been able to build those relationships also with our pediatric team and our special care nursery or our NICU. And so we really have found that the more planning and kind of wraparound team-based care that we can provide for people, the better things go. So the more we can introduce people to what the expectations are, introduce people to the team that's going to meet them, and have the hospital know to expect folks, the better things go. So it's not that kind of chaotic, traumatic situation that I'm sure have all seen examples of. So this is just, move myself out of the way. So yeah, this is just an overview of kind of what it looks like to move through our program. So midwifery care at our clinic here where I am today. And we collaborate with OB and addictions medicine in our hospital. We provide social work support and a lot of support navigating child protection. So that is a huge piece of this when we know that people are at risk or, are almost certainly going to have some kind of interaction with that system. Our approach has been to be very upfront about that, discuss it, and then offer to support people to build those relationships with Child Protective Services prenatally, so that we talk about kind of building a resume or a CV so that they can demonstrate, attendance at prenatal care, all the things that they're doing to work towards parenting, if that's their goal. One of the other important conversations to have when someone walks through the door is what is your goal in terms of parenting? And we have had clients who have chosen private adoption, which is another less traumatic way to move through this process when, if parenting clearly isn't going to be an option, no matter what is happening in terms of support, then working with a private adoption agency that understands parents with a history of substance use can be another way where the parent can have quite a bit of control rather than just having that baby just go into the system and disappear. So we've had some good experiences with that. We built relationships with organizations already doing this work because we were really new to this work. So places like Gene Tweed and Breaking the Cycle and Nurses in Toronto Public Health. The piece around connecting to pediatrics and seeing the nursery or the NICU beforehand is really key. And so I was asked to talk about Eat, Sleep, Console. So I'm just going to move on to that kind of focus. So Eat, Sleep, Console is an evidence-based approach to dealing with babies who have neonatal abstinence syndrome. So babies who are in withdrawal. It tends to be more focused on opioid withdrawal, but it can be implemented with a variety of substance use history and polysubstance use. And so it is a practice that aims to support the newborn that's been exposed to substances in order to help that baby achieve developmentally normal eating, sleeping, and consoling and weight gain. So in this model, parenting, or the parent or the caregiver, the person caring for the baby, does need to have parenting as their goal. So I think that's just important to understand what the goals are and then have those line up. But if it's a person who really has the goal to parent, then they become the primary provider of responsive newborn-centered care. And we really are treating them like a dyad. We're wanting to encourage the reasons that the baby might be going into withdrawal that can affect how the baby's eating, sleeping, or gaining. So just looking at the bigger picture, there tends to be just the zooming in on the pharmacological withdrawal. But this model of Eat, Sleep, Console really encourages to zoom out a little bit, look at the dyad, look at the environment. So things like a quiet, private room are very key. This is evidence-based care, and the tool that, if any of you who've worked in hospital or with newborns might be familiar with, the Finnegan scoring system, which is not actually evidence-based, but is in wide use. And that scoring tool will lead to many more babies requiring morphine and admission to the special care nursery. So this model really promotes a dyad, the parent and the baby together. It promotes the use of non-pharmacological strategies to support the newborn during that acute phase of withdrawal. And it's an objective assessment tool, and it has a higher inter-rater reliability. So it's actually, it has been validated as a tool It's low cost and it is achievable. I'd say that the biggest challenge is around just nursing supports, because it does require one-to-one nursing and it does require private room. And I know, especially in this context of the healthcare crisis that we're in across the country, you know, we have nursing shortages everywhere, and sometimes room space is also a challenge. This is just a number of the resources that we have used and that other people can use. So Perinatal Services BC has excellent resources across the board for everything related to perinatal care, but this guideline is really useful. This one is from an American organization. And then this is another program out of BC. Yeah, I think I'll stop there. Like, there's more that I could say about our program and about this tool. Maybe I'll just show the tool quickly if I can. Oh, I don't know if I can. I have the tool pulled up on my screen, but let me see if I can show it to you. Maybe not. I will stop sharing. And but there is an actual like tool that can go into charts. I'll just hold it up. So it looks like something that you would see in an EMR. Yeah.
Someone asked if there's any way you can put a link to the tool in the chat.
Sure, I absolutely can. I am now going to sharing my screen. Okay.
Okay, and then I'll just I'll ask you one question, and then we'll save the rest for the end. Someone asks if you've had any feedback from service users.
We've conducted some exit interviews with clients that have gone through this pathway. It's something that is still really iterative and we're building all the time. And yeah, we've had really good feedback. We've had people say things like, I wouldn't be alive if I hadn't met this team. So definitely, we have still, I don't off the top of my head have the numbers of like apprehensions avoided, but we definitely have had clients, like there have still been apprehensions in some cases, like some people are just coming to us with a level of instability that is just really difficult to manage in terms of parenting. But we have definitely had also clients who had they just shown up at the hospital, certainly would have encountered an apprehension and instead have taken their babies home. So that's been very gratifying. And we've been able also to involve families in some of that care. So in a couple of cases where grandparents who otherwise were estranged came back into the picture and were able to support the parent and the baby and able to go home together that way. So yeah, just the kind of the wraparound care in pregnancy and the ability to identify where the resources are. We've also been able to connect people to rapid titration of methadone on our labor floor. And so that's another piece where when people are ready and interested in accessing OAT, then being able to have the support to do that prenatally and then be stable at the time of delivery obviously makes a huge difference.
Are you involved when there is a child apprehension? Yeah,
we stay involved. So our ideal situation is that we are connecting people prenatally with Child Protective Services. So that's how we really like to work. And then when that happens, we get assigned a worker. And so one of the things I didn't talk about a lot is we have something called a specialized care plan. So in addition to the routine perinatal record that we have for all of our pregnant clients, we've developed a plan that identifies all the supports and all the care providers in this person's life, and that goes to the hospital team. And we have a nurse educator who also lets the nurses know when these clients are expected. So we just do a lot of preparation of everyone, like this person's coming. The specialized care plan makes it so that they don't have to tell their story over and over again, and also documents who to call if there are issues, if there are concerns. And we're kind of first line for that, but then someone like their assigned child protection worker is on that list. And so, for example, I've had a delivery like on a Saturday night where there's substance use history and ongoing substance use, but we were able to say, nobody needs to call, this baby's going into the NICU. nobody's going anywhere, and we'll call the known worker on Monday morning. And that's what we did. So things like that, where it's just that kind of agitation in the hospital that, oh, with this situation, we have to call CAS. When we've done this kind of planning and preparation, then we can say, it's okay. We don't have to call a random covering worker at 3 a.m. on a Saturday. We can wait till Monday and call the person who knows this person, who knows the plan. So that really cuts down on just those traumatic interactions. And when there have been apprehensions, yes, we're involved. My team has even sat at court hearings with people. And so just that kind of support that Julene was describing, to be able to do knowledge translation, explain what's happening, get them to those appointments, and help advocate for visit access when those cases are being decided.
So did I understand? So child protection is involved right from the start then? That's
been the approach that we've taken. It just, when people are coming in pregnancy with active substance use, unfortunately, given the system we have, it's just very difficult to interact with the hospital system and not interact with child protective services. And so we've taken the approach of just talking about that very frankly from the start, rather than trying to avoid it, addressing people's past trauma history. And we do that with our social work support and connecting them to other organizations like Jean Tweed. And we've accessed lawyers for our clients through those partner organizations. So instead of trying to avoid this and pretend it's not going to happen, trying to do it in a good way with a lot of planning, with a lot of known players, so that even if that's where things land, it's not happening at 3 a.m. with someone you've never met and just like the baby's gone, that's it, you have no access. You know, it happens in like worst case, it happens more slowly and with a lot more control and a lot more process and a lot more like support and guidance. So I would love to overhaul the entire child protection service. Like that whole part of our system could be so much better in terms of how we could support people, but we're working with the constraints that we're working within. And so we try to just, like sometimes I describe us as a snowplow going down the road. So clients are, when you get to drive behind a snowplow and the road is cleared, like we can be that kind of protection in front of the client so that they're not making that first contact. They're not having to tell their story 50 times. Like we've already set this up, it's already prepared, and we're smoothing the path so that they can navigate a system that really, frankly, isn't set up for them, expecting them, or really wanting them to be there. And so we just try to allow them to move through the system in the smoothest way that they possibly can.
So are there people that don't enter your program because of that condition?
I wouldn't call it a condition. It's like we don't make that call without people's permission. I'd say that we have a really high rate of like in the way that we explain it and discuss it, usually often at our first visit, that people really understand. And we work on building those trusting relationships. We also tell people like we have no grounds to call in pregnancy. And so we won't make that call until they're ready. And so sometimes that takes many, many weeks and many, many visits. And usually when we make that call, we make it together. So either with our social worker or with the midwife or both, we all sit in the room and we make the call and we say like, this is the case, you're likely to be interacting, and we'd like to make a prenatal referral. It's voluntary. And we have some prenatal programs in Toronto that we're lucky to have, where they have workers that can be assigned prenatally. They have no legal power at that time. So people can just start to build those relationships and make a parenting plan with a known worker.
Just ask one more question and then save the rest for the last. Can you speak to supports you have for gender diverse people who become pregnant?
Yes, that's, I don't know, like with substance use or just in general. I'm not sure.
Maybe both.
Maybe both. We in general in our program, we endeavor to be inclusive in all of our language. I think you probably haven't heard me say the word mother yet. So we just take a really gender inclusive approach as a team. all the care that we provide for everybody who comes through. We just don't assume we know anything about their gender. So we ask, and then we document it if they want us to, and we get that information through a conversation with our clients. So I don't assume that someone is a mother or wants to be a mother, whether they're cis or trans or non-binary. Like, that word is also very loaded for people, especially with trauma histories around CAS particularly. So those are the kinds of conversations that we have with all of our clients, like just what their relationship to parenting is, and what they want from us in terms of how we're going to be, like, you know, I'll say to people, if I'm talking about you, how do you want me to do that? Because I will very likely be talking about you to colleagues. So pronouns, but also the entire picture of just getting to know people. And one advantage of midwifery care is that, like, long relationship over the childbearing year. So we do get to know our clients really, really well. We go into their homes when for people who are housed. We go into shelters. So yeah, we tend to just know, and we don't assume that we know before they tell us.
Okay, thanks very much. Great presentation. So our final speaker is Hawkfeather Peterson. We work closely together for our group's called PAC, Parents Advocating Collectively for Kin. Hawkfeather is one of our 3 coordinators. We also have 2 Indigenous coordinators, and Hawkfeather brings lived experience to the work, and Hawkfeather can do more of an introduction and description of what our program does.
Yeah, hi everybody. I'm just going to put my camera on for a second so you can see who you're listening to. But my child is sleeping about a foot away from me. I don't know why he's still, it's kind of early still. But I'm going to have it off because at any point you might hear him. He'll sit bolt upright. He's not clothed. I'm just going to keep my camera off. But I just wanted to, I think it's better if you see who you're engaging. So hello. Yeah, my name is Hawkfeather Peterson. My pronouns are they, them. And as Keri said, I'm one of the project coordinators with PAC. We are a peer-led organization that works trying to address the inequality and injustices that face mothers and birthing parents that have been substance users. Primarily, we end up focusing quite a lot on the risk of apprehension. And yeah, we're trying to create some learning materials to increase capacity for existing outreach workers that are peer support workers, so that they also know how to try to, you know, advocate and support a peer that is risking the violence of MCFD or agency and ministry engagement. So yeah, it's hard work. It's just absolutely traumatizing and devastating. And, you know, we started this work really heavily focused on creating these educational materials, but right away it was very, very apparent that the need for one-on-one support was so extreme that we almost haven't had time to even focus on the educational components, because so much time and energy has gone from our coordinators literally providing the respite care and support and showing up at meetings and trying to do their best to right wrongs in a very severely biased system. So yeah, that's a bit about PAC. Yeah, and today I'm speaking from a perspective of lived experience, but also as someone that works within the field of harm reduction. I was an outreach worker for many years. I am the regional peer coordinator for a health authority here in our province. I do this work with PAC, doing, you know, frontline hands-on work. And I'm also doing, you know, speaking from a perspective of care provision. Pardon me, I'm losing my voice already. It's not a good sign. Yeah, I see great care providers here. This is a powerful group, and I'm super grateful for these conversations. I know I just kind of wanted to take a moment to personally acknowledge that, to me, one of the most significant things we can do, or that people, you know, care service providers can do to take that preliminary step towards providing really meaningful and beneficial perinatal care to substance users is to work towards unpacking their biases and really exploring the inequalities that exist within our systems here, whether it be healthcare, social justice, but also encourage people to really graciously explore their own personal biases, because they creep in there and it can be a really difficult conversation. I think that we often see, care and service providers looking for ideas for how to best address situations where they're providing care for mothers and birthing parents that use drugs. Like tricks and tips. We often hear the term, they're looking for tricks and tips to how to improve their harm reduction care. And I always say, I kind of feel like that might deserve a little exploring in itself, because I feel like something that gets neglected way too often, almost fundamentally neglected here, is that, a mother or birthing parent that is a substance user deserves the exact same harm reduction as someone who is not pregnant or parenting, but that just isn't the case on the ground. We just don't see access to harm reduction services as readily available. The scrutiny and, dare I say it, prejudice that exists towards mothers and birthing parents that use drugs is just so deeply entrenched in personal views, but also within policies and practices, that I think people sometimes don't even see the harm. And what we see happening is that we end up with gaps in very simplified services, just accessing an OPS. I think people don't even consider the difficulty in a visibly pregnant individual accessing a safe consumption site, and what barriers they might face walking into a care provider's office and asking for safer supply, where they might be told that, they have to be reported to the ministry just for seeking life-saving services. So I just, a really big part of what I want to say here today still really centers around ensuring that basic harm reduction is accessible without those biases. I really think that if we really are very honest and truthful when we look at services and programs that exist for mothers and birthing parents that use drugs, I really think it becomes really glaringly obvious that people are still just very uncomfortable with the idea that there are drug users that are pregnant. And what that does is creates like massive walls, not just barriers, just absolute walls against seeking your own care. We know there's been recent reports, they didn't need to exist, we know it, but still it's really great to have these reports that show a link between fatal overdose and child apprehension. So we know that having our children taken is deadly in our community, a community that's already being, decimated, really, just absolutely destroyed by the toxic drug supply and the toxic drug policy that exists in our country. But we are still providing haphazard and lacking services to one of our most vulnerable populations because of our own personal biases and our discomfort with the fact that parents can use drugs. I still think that there are probably beautiful people here that are working really hard to support and help people who, if they really truthfully unpacked their own perspectives, really feel that harm reduction when it comes to pregnancy should look like the mother or birthing parent stopping using drugs, and that should be the front line, the hard line for harm reduction for pregnancy. But all that really does is create more of a barrier to care, in my opinion. I think that it's great that there's options that exist that, could walk through and support someone in seeking treatment options. But here, in reality, we have a large population of people that use drugs that are completely neglected from dialogue, from policy, from practice. And really, when it comes right down to it, if you want to keep your baby and you want adequate healthcare, you lie. You have to lie. You have to come into the room and you have to tell a story that you think they want to hear, because you don't want to have your baby ripped away from you, and then you don't want to end up dead because the trauma is just too much to bear. I do think we've come a really long way in perinatal healthcare when it comes to substance use. We have a lot better understanding of treating neonatal abstinence syndrome. I still see it diagnosed based on stigma rather than medical experience. I still see babies diagnosed with NAS based on very typical newborn behavior. But, a nurse might see a tremor on a baby that they know that mom has a history, and so that baby gets slapped with a diagnosis, and that label can follow that family for a lifetime and impact whether or not that family can successfully parent. And I think that that's still happening while we're seeing birth alerts discouraged and eliminated, even in provinces like BC and other provinces that have eliminated birth alerts. They're still happening, despite the harms that have been recognized in the inherent racism and colonial impact there. We have more children in British Columbia in foster care than we ever had in residential schools. So I really think there's some glaring faults there with the family policing state in our country. If one family can raise a child safely because of the color of their skin, and the next family has that child taken because of their child of the skin, the color of their skin, clearly the drugs weren't the problem, right? It is, I think, a very outdated perspective that you can't successfully parent and be a substance user. And while we move to solutions for the overdose crisis related to safer supply and decriminalization, I really do think we're going to have some really hard conversations about biases and how they're harming substance using mothers and birthing parents. Because right now, those people are being left to die or to just linger in trauma, and their children to suffer injustices and inequalities. I really think that, while we start coming together, I think too often substance use care ends up painfully siloed, and wraparound services are really, really important. So I think conversations like this, where we come together and bring all these really unique and diverse perspectives together, are such a beautiful and powerful opportunity for us to start really exploring the biases that exist out there around substance use. But I know for me, in a perfect world, we wouldn't be forced to alter our narrative to appease anyone. Our stories could be our truths and reflect the beauty of our families, and we could share those openly and seek care openly, and not be afraid that when we go and just try to protect our little one and protect our lives, that we could end up losing our children, losing our families, losing our homes, because that's the reality now, is that seeking really good care puts you at risk of harm. And I don't know how we can face this work without trying to address that objectively and trying to change that. So I do think that there's quite a lot of activism that needs to happen, where we promote a greater tolerance and understanding of what active substance use looks like in a successful parenting situation, and learn how to increase peer supports so that people can objectively and honestly share their stories with people without fear of cost of disclosure. I think that when we look at mandatory reporting, I'm just not seeing that being anything that is meant to actually benefit families. I just don't. I think we sometimes hear the term mandatory supporting instead of mandatory reporting. And I think that moving into a reality where that's what we're talking about is just much more beneficial. So for me, I guess I kind of just want to remind people that harm reduction is reducing the harm in people's lives, and to truly and honestly reduce the harm people are exposed to, that requires some very honest and sometimes very difficult unpacking of biases. And, you know, we're not here to judge people for having those biases. They're pretty inherent and we all have them. But we're here to support people if they have a desire to unpack some of those biases. And as a person with lived experience that is working in this field with my wonderful allies and peers, we really are very available if people have a desire to explore a greater understanding of how to support active substance users without forcing a recovery or abstinence narrative. So if people do want to explore what that looks like, we're super available to talk further. And I could go on for weeks and weeks, but I will stop here and see if people have any questions. So thank you for the time, everybody.
Thanks, Hawkfeather. That's great. Yeah, and we would like to see what we're doing expand across Canada. I'll just mention a couple of comments for you, Hawkfeather. One was from Murray, who says, "Preach. The stigma is real. I appreciate this work and advocacy so much." Another one is speaking truth to power, Hawkfeather. Thank you. Jerry asks, "No one has addressed the health outcomes for the infant whose mother was taking drugs. Only immediately, but long term." Do you have any comments on that, Hawkfeather?
Oh, yes, definitely. I think that is such an absolutely wonderful example of how biases harm. Because
sorry, can I just add one thing before, because Jenna actually makes a good comment that kind of goes with that. She says, or they say, also, who gets scrutinized for using drugs while parenting isn't everyone. So lots of people use drugs while parenting, and lots of people are not scrutinized for that. So that kind of goes hand in hand. So yeah, go on.
Yeah, absolutely. I still see some very outdated and not evidence-based ideology promoted as healthcare. And I find that should be really challenging everyone here. We debunked a long time ago the myth of the quote unquote crack baby and the long-term harms there, but people still equate certain substance use with long-term harms. We know that a lot of substances that are taken are not teratogenic. Pardon I stumble over that word all the time. But we know that stigma is informing people's perspective of what they think harms are happening to babies. But when it comes right down to it, we also deserve autonomy, bodily autonomy for our care. And when it comes down to it, we often see the needs of our children and our babies prioritized over even just staying alive. In a deadly healthcare crisis, that isn't a risk I think we should be taking, where we sacrifice mothers and birthing parents because of the assumption that substance use may, cause long-term harm. The ethics of really exploring how illicit substances impact children in the long term really affect what knowledge we have. And very rarely is it separated in studies that have been done. They rarely separate the harms of criminalization and the harms of being stigmatized, the harms of being ostracized from the harms of substance use. So, what we do studies and they say, people thought that cocaine was this problem for these babies, but what was the real problem? Poverty. And that's something that everyone has a responsibility to address in society. So I guess I'm really exaggerated what I'm saying here. What I'm really trying to say is, I think that the harms of substance use are often grossly exaggerated due to stigma. I think that that serves a real, it serves a real injustice and creates quite a lot of risk. So I think that if you really want to look at, what's causing a low birth weight for a baby, is it fentanyl, or is it the fact that mom couldn't eat or parent couldn't eat all week successfully? What affected this baby being born prematurely? Was it, the methamphetamines, or was it the domestic violence, or the lack of rent this month, or the housing insecurity? We don't know. I think that there's a lot of determinants for health for substance users that we never even touch, because we are so obsessed with the wrongs of drug use, and people are so obsessed with drugs being unethical and being immoral that we don't even try to ensure that the determinants of health for substance users are actually adequate. So yeah, I'm on another rant, so I apologize. I'll stop.
So
Can I just second some of that, like just in terms of the literature and the outcomes for babies? Like, we know in terms of drugs and drug use, like the one that has like, I think, good data and demonstrably long-term effects is alcohol. But in terms of other, which is our one legal drug, is the drug that actually really does cause some irreversible harms depending on the context. But in terms of illicit drugs that people are using, like opioids, those babies do quite well. And it's really interesting in the adoption agency that I mentioned that we worked with, who work specifically with families with complex histories and doing private adoptions and open adoptions. That worker who'd been doing this work for 30 years said, "Oh, we love like cocaine, opioids, those drugs, like no problem. Like people want those babies because those babies do well." And so we don't actually, and just to echo what Hawkfeather was saying, like if we look at the data on cannabis use, which is now legal in Canada, so hopefully we'll get some better data, but when you read the studies that most people are quoting are from 30 years ago, and they're real lousy in terms of correlation versus causation, and being able to tease out the other social determinants of health, so poverty, food insecurity, stress, these types of things also really do contribute to problems in pregnancy. And so we're just in the perinatal space and postpartum for those babies. There's initial need for care sometimes, especially with opioids. Like withdrawal is real, neonatal abstinence syndrome is real, and we do see those effects, but they're short-term effects, and we don't have good research that's showing that, oh yeah, there's 10, 20 years down the line there are these significant problems for these babies. These drugs are not really the evil ones, and we've decided that one is legal and one isn't, and it's just interesting when you look at those kinds of effects.
Yeah, it's such a good point you raised. If that was more general knowledge to the wider public, there might be less stigma.
Absolutely. Babies born today in good healthcare services, like in good, hospitals and with good care providers, the same exact situation, that baby 5 years ago may have been given morphine and walked away from their care with an addiction due to the medicine they were given in the NICU. And today the treatment is a hug, right? And I say that, I'm not trying to be myopic in saying that. We literally know now that a baby that can be crying and having a tremor can absolutely calm right down and be completely content and nurse happily with a really well-supported parent and child dyad. And we still see awful videos that come around about these poor abandoned babies born to the opioid crisis, and they'll show a baby having a seizure and claim that it's a baby in withdrawal, or they'll show some absolute worst case scenario, but really a lot of it is just so grossly exaggerated. When I was having my son, who is now 6, I wanted a home birth, and on methadone, I wanted to double check with an OBGYN because I was having midwifery care. And I went to an OBGYN who had very gratefully just done some, secondary training around perinatal healthcare for substance use. And he absolutely approved having a home birth because he said, even in this day and age, we're not going to be treating your baby. Your baby will be fine. The amount that you take, your baby probably won't even notice, and you're going to be nursing and it'll be absolutely fine. And in the end, the greatest harm my child suffered was from stigma, because we ended up with complications in an emergency C-section. And, that he came out after I was given general anesthesia, he came out floppy, and their immediate response was to give him naloxone. But as a methadone patient, he had developed always having opiates in his system. So he went into shock and respiratory distress and has cerebral palsy. And really, sorry, that I truly believe that was a decision made in a moment of stigma and prejudice against me. And it isn't recommended to give naloxone after a C-section to a baby that's been, born of a parent on methadone. And I really think, people get so fixated on, neonatal abstinence syndrome and all these potential long-term harms for children. Meanwhile, here's a lifelong harm, and it really is from stigma.
Yeah, I guess there's no way of knowing it, but you would hope that never ever happens. But yeah, horrible. Yeah, the stigma, like someone said, is real, and it seems pervasive. I just wanted to point out that our group, PAC, is we are also the recipient of a SUOP grant, and we're also funded by the Canadian Women's Foundation. So that's where we've been getting a lot of our funding. I'm going to open up questions to everyone now. Julene, there's a question about your pilot project. Has it been published? And is there a link for your program?
It has not been published, so I'm sorry, there is no link for that. But if you have any further questions outside of that or something, I might be able to find something to send. So I don't know if you want me to put my email address in the chat for anybody to contact me.
Yeah, that would be great. And then another question is did the pilot stop? Someone is saying, do I understand correctly that the services are still there for pregnant women and people on a voluntary basis?
So the pilot project itself has come to an end because our birth alerts came to an end, and that was the reason that the pilot project had come in the first place. So that would have been set up for moms who were flagged and were at risk of having their baby apprehended at birth due to the birth alerts. But of course, the supports that are still needed for prenatally are still there. And that those supports never, like the need for those supports never go away. So we still absolutely do provide supports to any of our moms that come to us that are pregnant, or if we have any referrals from social services or other outside agencies, or even from the moms themselves, we'll absolutely help with any supports that they need.
So it works together with the family support program then?
Yes, yeah.
And that's the one that's 365 days a year. Yeah,
you betcha.
There's a question about hospitals and safer supply. What has this response from OBs been like, specific to clients on safer supply? Jenna, did you want to start with that one?
Yeah, we have had one of our clients, so we have a safer supply program here at South Riverdale CHC that's run by our NP and nursing colleagues. And we've had one of our clients access that program during pregnancy and then postpartum. And that I think went quite well. That's one of the babies I mentioned who went home with the parent and grandparent. And yeah, I think it's just like maybe a challenge around when the care is moving from community to hospital, like that's one of the biggest challenges we face. So we have community-based providers doing the safer supply work, and we do actually have a decent addictions medicine team that when they're there are really, sorry. There's a overhead announcement in my clinic. Yeah, like I said, we've had 2 OBs out of our team of obstetric providers really step forward to support us in this work. And so we mostly are just working with the 2 of them. So they know us and they know these folks. And then our chief of peds as well has been really supportive. So they're meeting those providers prenatally and everyone knows the story. Like that's just the relationship piece, and the prenatal planning piece has been so key for us. And we've run into challenges around like pharmacy, just navigating that, especially after hours, getting the right medication, like challenges around having morphine, oral morphine available in an adult dose and not a pediatric dose. There's all kinds of like small details like that once you start trying to provide this care, like you realize that you need to work out. And that's just that institutional navigation and being able to build relationships within the institutions you're working within. So we meet as a team at our hospital and review each one of these cases and identify what worked, what didn't, and then we keep going. You know, everyone is also so unique that it's hard to necessarily fix all the things, I think. But yeah, we have been able to access, you know, we've had clients who are receiving safe supply even in the hospital postpartum, and one of the things that we've been able to do is implement using some alertness scales like COWS and PALS, so that the postpartum nurses feel safe to be able to assess like how is this person doing. So if they're going to go handle their baby in the NICU, are they alert enough? Like, are they receiving the right dose? Because people are receiving much higher doses generally of methadone or whatever it is that they're using in pregnancy, and then it is a bit of a dance to get that titration right in the immediate postpartum, because we don't want to just tank their dosing too quickly, but we also know that the metabolism changes very, very quickly as soon as pregnancy is over. And so it really is like an intensive process with addictions medicine in those first few days. And we tend to keep our folks on the floor for 5 days, 5 nights. So that's another way that we just continue to provide like support, and we don't have people just leaving the hospital and then having to come and go. So if their babies are in the nursery, they can access them. I hope that answers that.
And then there's a follow-up question. Does your local hospital order the same supply dosing meds that are prescribed by the safe supply practitioner once you're admitted to hospital? And do the patients need to leave the hospital to obtain it?
No, they don't. No, we've been really lucky to have, especially a couple of addictions medicine providers just like get really involved and support these cases. I'd say like we're the communication piece between community and hospital. And so I would dream of like having that be more integrated, like have our community practitioners have hospital privileges the way I do. Like that would be a lot easier because we're the only ones who work in both places. And so, but yeah, no, I think like in general, I've seen Kadian and Dilaudid being used in combination, and that works quite well. And then when people are doing rapid titration prenatally, then we're using oral morphine and methadone as they're titrating up. So oral morphine to manage the symptoms as we get them to a reasonable dose of methadone.
Jenna, has your group, did you come into contact with a lot of medical health professionals, obstetricians, midwives in your program?
Sorry, who are you asking, Julene?
I'm sorry, yeah, Julene, sorry.
Yeah.
Sorry, what was that?
Do you come across many medical health professionals in the work your project's been doing, like obstetricians, midwives, doulas, and has that been a positive experience?
We'll sometimes get referrals from OBs, Healthy Mother, Healthy Baby, Westside Community Clinic. But we don't work so too close hand in hand. But we absolutely, like, if we have someone who's wanting us to be more on a collaboration with their doctor or their OB or somebody, absolutely, we're definitely open to doing that for sure. Yeah,
I would love to partner with you in my community. Like, it makes such a difference to have those non-clinical support people. Like, that's really key actually, is having that partnership. Like, I can do the parts that I can do, and we do kind of case manage like from above, but we really do need those other inputs that are non-clinical.
We do.
So, yeah,
we do. And like we'll have lots of referrals from other community agencies as well for us, and I would love to work with you as well, Jenna, for that. I do want to comment, like, here in Saskatchewan, we do not have a safer supply program at this time, which it also causes a huge barrier for us as well here.
I guess one question for everyone is, for all the teams, is what level of BIPOC staff do you have, and people with lived experience, and do you have peers in your programs? Julene?
We absolutely do. We love hiring with lived experience. They have so much valuable expertise and experience to offer to our PAWs, to our clients, to our staff as well. So we do hugely look at lived experience when it comes to hiring, and we also make sure that we do focus on hiring BIPOC as well. Indigenous people of color, absolutely. We want to make sure that we are as inclusive as possible on our team in all of our programs with our entire organization.
And Jenna, your group?
We have on our team of 4 midwives. 2 of the midwives are white. I'm one of them, and 2 of the midwives are racialized. And we're hiring a 5th midwife, and we always are prioritizing those hiring spots when we can. And then in the wider organization, so South Riverdale really thrives on lived experience, like the people who are staffing our outreach work and really frontline community-based work are almost exclusively people with lived experience, and we have really leaned on the harm reduction workers and the nurses in our safe supply and our safe consumption site to be able to support people and collaborate and provide that care. We have lots of Indigenous staff here at the health center, but not on our team. And there's a midwifery practice group that is focused on Indigenous care provision and midwifery down the road. So actually, if people identify that they're Indigenous when they come into care, we always make them aware of 7th generation midwives and offer a referral to that practice instead, if that cultural safety component is key or important. And we've had some people take us up on that, and other people who have such a strong relationship with South Riverdale that they've chosen to stay with our team, even though we don't have an Indigenous midwife. We do connect with, there's an Indigenous Pathways worker at Jean Tweed, and so we've worked a lot with her to provide that support for people who are looking for that.
Nice. Rebecca is going to launch a poll. Do you want to speak to that, Rebecca?
Yeah, we'll just, people can continue on with the conversation. We've got about 12 minutes left, but we just are going to put a quick poll up. If you could just take a moment and fill that multiple choice poll out for us, that would be great. Thanks. Carry on with the conversation. Sorry to interrupt.
I did just want to add that with PAC, when it comes to representation, we have 3 project coordinators, and as I think Keri mentioned earlier, 2 of which are Indigenous women that are coordinators, and I am a non-binary parent, birthing parent, and it is a peer-led organization. So PAC originally came from BC Yukon Association of Drug War Survivors Women's Committee, and the project was identified from that group, so it was entirely peer-led. But we do work with some really powerful allies that I'm profoundly grateful for.
One of the other things that we were starting to work towards pre-pandemic is a patient advisory group to kind of almost like a mini board of directors to steer our program. So we had a student did a bunch of research, and we were starting to look at how we could build that in a good way. And then the pandemic happened. So I think it's something that hopefully we can bring back, but we're really interested in having that guidance coming from the community and that feedback. So I would prefer to be running our program with that like permanent kind of client and patient input.
There's a question here about the use of self-sufficiency matrix type tools. Jenna, is your tool a little bit like that?
I mean, it's not my tool. It's Peri Natal BC. It's from that guide that guide that I put up. But it's just like designed. I would think I can pull it up again. It's like designed to go in.
I can't hear you for a moment.
Oh, so you're just running through. It's an assessment tool that I think you could put into your electronic medical record system and then use, or do it by hand.
Okay, and there's a question here. I just wanted to clarify, if someone who uses substances presents in labor at the hospital on the weekend, the decision can be made to allow parent and child to stay together over the weekend, and a call can be made on the Monday. I'm assuming they mean to child protection. Does anyone comment?
We will get calls from our ED or from our labor floor now. So so for people who show up who haven't accessed us prenatally and who show up with no prenatal care and with a history of substance use, we've gone many times now. So we always have a midwife on call, so they can page the midwife on call, and we've had both our ED docs and our OBs make those calls to us, and then a midwife goes in postpartum and does as much case management coordination, connecting to services as we can. So that's something that has changed in our hospital. You know, there was no plan for those folks, and now people tend to know to call us, and it does make a difference in how their postpartum process will roll out.
Okay, and here's another question that you might have some knowledge about. Is if someone is stable on safer supply on Cadian, is it conventional wisdom to continue this during pregnancy rather than switch to methadone, about which there is more evidence for safety? Is that, I don't even know if that is there more evidence for safety on methadone?
I mean, the problem with pregnancy, with like even drugs that are sold at the pharmacy, is that we often lack data in pregnancy because the research isn't ethical to do. So it is a huge gap in terms of like evidence. And I think it's a place where people are cautious around like safe supply providers. We have had providers who've been willing to wade into that. And there's someone in Hamilton who has mentored some of our providers who has more experience in pregnancy, but it's like pregnancy is always a place where people are like, oh, I don't know, I don't do that. I do everything except this. So it depends, like it's provider specific, I think. We have had one client who was using street supply and then got stable on a Cadian dilaudid combo. And then other people who have chosen to do rapid titration of methadone. I haven't seen that case of like already stable on safe supply, then pregnant, and then what do we do? I think it would be a discussion, and we would involve all the providers to make the best decision, including our addictions team at the hospital. I don't think there's like a conventional wisdom about that. I don't think there's enough experience with it. We're not there.
Okay, Marie actually, she clarified about the self-sufficiency matrix. She's wondering if you, and I guess this goes for anyone, get patients or clients to do a self-assessment of their general well-being, and if that gets reported anywhere. I think it would be a useful tool, but can anyone comment on that?
I don't have like a tool. I don't think it's part of the discussion, identifying strengths and weaknesses and goals. So that's definitely something we talk about, but I don't have like a validated tool that I use for that. I don't think. Maybe if Shazine is still listening and I'm forgetting something that we do, she can tell me.
Julene, are you aware of one of those? self-assessment tool?
No,
I
we don't.
I know
We
that,
don't use those.
I'm sorry to interrupt you. I'm sorry. I was going to say I've experienced some assessments like that, and I often find them to be fairly paternalistic. But that doesn't mean that one couldn't be developed. That would be fabulous. I do think that this discussion really should flag the need for peer support workers to be really actively involved with patient care and ongoing support, because I do think that when it comes to open and objective disclosure and dialogue, I really do think peer support workers are the best line of defense to make sure that we're really making sure, you know, a patient is comfortable and can share without fear of prejudice or harm.
We do a lot of identifying strengths for people. So I think people have experienced so much stigma and, you know, there's so much shame wrapped up in all of this. That like often a lot of what we're saying is like, you are an amazing parent. Look at all of the things that you're doing. Like you've come to your appointment today, you've eaten today. We give out grocery cards, we have food in our clinic. So, you know, just those very basic things that people who aren't facing this kind of stigma and scrutiny and judgment like would inherently have a sense of like pride about having had breakfast. Like, you know, for many people, that's not something they have to put effort into, like having some pride and self-worth around those things. And so a lot of our work is reflecting back to people like what incredible parents they actually already are even before their babies are born. And so we do a lot of that conversation. Just like, look at all the ways that you are already taking care of yourself and this baby. And with the prenatal meetings with our team, like our pediatrician, one of our pediatricians who's done a lot of this work with us said, I never know any of our patients who like come through the NICU. Like I never get to know these families. They're not here long, but our matched up patients, I know them so well. I know their grandparents. I know their parents. Like that you can, with that relationship building, then that reflective process of like, you are doing a good job as a parent, it needs to be said out loud and should be said out loud. And it's something that I think my team does a lot of.
I will say too, something that people don't consider very often in doing this work is that substance using mothers and birthing parents rarely have an opportunity to celebrate becoming parents. We're not out there on Instagram having gender reveals and big celebrations and parties. We're worried about survival, and we're worried about having our babies snatched. And, you know, and that doesn't mean that's true for everyone. Obviously, of course, there are people that do have an opportunity to celebrate, but so many families have been destroyed by stigma and the war on drugs that and there's so much negative bias against parents and birthing parents that, you know, mothers and birthing parents that use drugs. The opportunity to simply celebrate with someone, if it's a celebratory situation and they're choosing to continue on as parents, then taking a moment to share, you know, like there's nothing worse than having your baby in the NICU and watching all the well-dressed parents with their expensive car seats leaving the hospital, barely able to carry the balloons and flowers with grandma and the photographers, and you're there just desperately hoping that day you're going to check all the boxes so that you're not going to be targeted.
Yeah, I just want to say, like, I hope that can change where all births are celebrated, and we're coming close to the end here. I just wanted to raise the topic of peers and the use of peers in this work, because we're finding like setting up the safety plan is much easier with a peer who has that lived experience, especially having gone through that birthing process themselves. So that's one thing that we would like to see, you know, way more widespread use of peers in this work. Because we only have a minute left, did any of the panelists want to make a comment?
I just want to thank everyone for joining this conversation. That's very important to have, and it needs to be an ongoing conversation continuing down the road. So I think this was absolutely wonderful. And I thank everybody, all the participants who had joined in to listen, and the questions that you asked were absolutely fantastic.
Yeah, I would second that. Thank you so much. I put in the chat, but we have a Polaroid camera. That's been something that's felt really good and popular. When babies are in the NICU and people can't go see them, we can bring a picture back, or we can take pictures of them at birth. It's actually, like, it's such a simple thing, but it's dramatic. Like, there's nobody there to take pictures, and so we do that for people.
Yeah, I just want to end by kind of saying, I really hope we're moving to a point where chaotic substance use is recognized as a harm related to criminalization and stigma, and that we're working towards combating that, and that an aspect of that will be acceptance of the needs of parents that are active substance users, and that their needs will be considered and biases will be addressed. And thank you so much for everyone. They're great questions, and this felt like a safe, good space, and I really appreciate the conversation.
Fantastic. Thank you all so much. Thank you to our audience for being here today. And big thanks to you, Keri, for moderating this panel, and Hawkfeather, Julene, and Jenna. It's just been wonderful to have you here sharing about your experiences, your knowledge, and your advocacy for this work and transforming care for people. I just want to do a quick plug that if you're interested in finding out more about the community practice, go to our website. We will be posting this webinar, the video of the webinar, up on our website. And you can also go to our website to find out about future events that we have, like the one we have coming up in September on safer supply in Quebec. But again, I need to end with, again, my sincere thanks to all of you for being here today and for having this conversation and doing this work, and helping us all move forward and pushing this work forward. Thank you. Thank you.